This is a surgical technique video detailing how to perform an endoscopic proximal hamstring repair. The patient is positioned prone with the Wilson frame to slightly flex and expose the ischial tuberosity, which is the origin of the hamstring tendons. The conjoint tendon is slightly more superficial and medial than the underlying semimembranosus tendon, inserting more lateral. Important surrounding muscular landmarks include the obturator internus found superior, the quadratus femoris, as well as the obturator externus, while the adductor magnus is found more inferior and medial. It's also important to identify the posterior femoral cutaneous nerve for preservation of cutaneous innervation, as well as the sciatic nerve, located more lateral. On entry, there's usually a cavity which comprises the tear and the ischial bursa. A combination of electrocautery and the shaver are used to identify the ischial footprint, as well as clear the surrounding scar tissue. The sciatic nerve is then identified and carefully protected throughout the case. It would be helpful to abduct the hip to move the sciatic nerve more laterally for protection. Next, we prepare the ischial footprint by a combination of the shaver, RF, and motorized burr for partial decortication. It's important not to fully decorticate in order to provide adequate support for anchors. Both the superior and inferior aspects of the ischial tuberosity from the medial and lateral extent of the footprint is debrided to prepare a healthy bleeding bed for later healing. The tendon edge is then identified and carefully debrided and released to allow adequate excursion. Here we can see the subgluteal fascia is being dissected both to help with visualization as well as tendon mobility. Once the tendon is circumferentially released, its excursion is checked to ensure a tension-free repair. Next, bow anchors are placed in the ischial footprint. Sutures are then passed through the tendon, and the tendon is provisionally reduced back to the ischial footprint. The sutures are then tied and passed through a superior medial anchor to allow for improved footprint contact area and enhanced healing. Final tensioning is then performed for each strand individually to ensure complete contact area, followed by placement of an interference screw for fixation of these sutures. Final construct is then evaluated and visualization of the sciatic nerve without any tethering or errant suture placement is confirmed. The final construct is then evaluated with gentle knee extension to ensure there is no tension or gapping. A knee brace is then placed at 45 degrees of flexion to protect the repair.